Hello, I'm Denise Lee. One of the most important roles we play as nurses is patient advocate and providing effective pain management. The Critical Care Pain Observation Tool, known as the CPOT, was developed to help nurses assess patients' pain when they cannot self-report their pain. The purpose of this video presentation is to demonstrate how to use the CPOT in clinical settings. It is now my pleasure to introduce Dr. Kathleen Puntillo. Kathleen is a professor emeritus and research scientist at the University of California, San Francisco. She has devoted her entire career to improving pain management for critically ill patients. Also presenting in this video is Dr. Céline Gelina. Céline is a faculty research scientist at the McGill University, Montreal, Canada. She is the lead author of the CPOT.
Hi, my name is Céline Gelina. I am an assistant professor at McGill School of Nursing and a researcher at the Center for Nursing Research and the Lady Davis Institute of the Jewish General Hospital in Montreal, Canada. As the main author of the Critical Care Pain Observation Tool, I was involved in its development and validation in critically ill adults.
Hi, my name is Kathleen Puntillo. 20 years ago, healthcare professionals thought that ICU patients were either too sick or too sedated to feel pain. My research and that of others has shown that patients do suffer from pain and they remember those experiences. Indeed, pain-induced stress can be harmful to a patient's recovery and might even contribute to death. As we saw in the Thunder Project 2, which was a study with over 6,000 patients, critical care nurses often perform procedures such as turning and ET suctioning that cause pain in their patients. As a result, clinical practice guidelines were developed that recommend medicating patients for pain prior to a procedure that is known to cause pain. A pain behavior screening tool can be very helpful to a nurse as long as it's valid and reliable for that patient population in which it's being used. However, we must understand that a pain behavior scale doesn't rate the severity of a patient's pain like a 0 to 10 scale does, but it does tell us whether the pain is present or absent. The CPOT was developed to help ICU nurses recognize pain in their patients, and it has been validated in many ICU patient populations. In fact, it is recommended for use by the American Society for Pain Management Nurses.
For the rating of the CPOT score, the patient is attributed with the highest score of each behavior observed during the observation period. Muscle tension should be evaluated last, especially at rest, because the stimulation of touch alone may lead to behavioral reactions. Let me now demonstrate how to use a CPOT on a patient.
The nurse looks at the patient's face and body for 1 minute to note any visible reactions. At the end of 1 minute, she gives a score for all items except for muscle tension. The nurse then holds the patient's arm in both hands, one hand at the elbow and the other hand holds the patient's hand. She then performs passive flexion and extension of the upper limb and feels any resistance. If the movements are performed easily and there is no resistance, the score is 0. If the movements can still be performed but with more strength, thus indicating resistance to movement, the score is 1. If the nurse cannot complete the movements due to strong resistance, then the score is 2. As a patient is being turned, the nurse looks at the patient's face to note any reactions such as frowning or grimacing. These reactions may be brief. As noted on the CPOT photos, a score of 1 consists of a tense face, which is usually exhibited as frowning or brow lowering. A score of 2 refers to grimacing, which is a contraction of the full face, including eyes tightly closed and contraction of the muscle of the cheeks. The nurse also looks at the body movements. For instance, a patient may be trying to reach or touch the site that is painful. This would be a score of 1. If agitation is included in the patient's movements, this would be a score of 2. Ventilator compliance is assessed by seeing if the patient is coughing and if the alarm is going off. If the patient's coughing and the alarm stops spontaneously, this is a score of 1. A score of 2 would be if the patient fights the ventilator. If the patient isn't intubated, you will hear or may hear certain sounds, such as moaning or crying out. Muscle tension can be felt by the nurse if there is resistance to movement. A score of 2 is given when the patient is resisting and attempts to stay on his or her back. The patient could also clench their fists.
Let us now have you practice using the CPAP on 3 different ICU patients. You will be seeing 3 different video clips demonstrating different patient behaviors. Using the CPAP tool, which was provided to you as a handout, assess and score the 3 different patients. Here with me is Dr. Kathleen Pentillo to discuss the 3 video clips. We will now see Mr. Dennis. So the patient is at rest. Face looks relaxed. The body looks relaxed as well. No alarms, so the baseline CPAP score would be 0. Now the patient is being turned. We can observe little frowning and weeping eyes. Some shivering here. The alarms are on. So repetitive movements of the arms, he's resisting the movement. So that would be a CPAP score of 5.
I agree. Okay, so we're going to take a look at our second patient, Mr. Doucet. And you can see that Mr. Doucet is very similar to the previous patient at rest. His CPAP score is 0. You can see that there are no facial expressions that indicate he's having pain. His body movements are virtually absent. Now we're going to see him when he's going to be turned, and we'll see the differences. Here you can take a look at his face, and you'll see that there's some grimacing. There's some frowning. His eyes are tightly closed. Now there's the ventilator. He's kind of alarming the ventilator during this turn. He was also hugging the pillow over his sternal incision. I'd actually give him a 5. He resisted movement, or maybe even a 6.
You're right. It remains unclear if the patient is fighting the ventilator or not, because this video clip is so short. In real-time observation, the nurse would get a better idea of this indicator. So let us now talk about the third video clip, Mrs. Asia. So we're seeing her at rest. Her face is relaxed. There's no frowning, no grimacing. And now the body view. She's lying quietly, no body movements, no alarms. So it would be a CPAP score of 0, like the last 2. So we're now seeing her during turning. A second view. Oh, a little frowning, and she closed her eyes. The turning is easygoing. She doesn't seem to resist.
I agree.
And no alarms. So it would be a CPAP score of 1.
Of 1.
All 3 patients that we viewed on the video clips were intubated. However, it may happen in your practice that the patient you are assessing is not intubated. In such situation, the nurse would look for the patient's vocalization. A patient who is talking normally or remains silent would get a score of 0. A patient who is moaning or sighing would get a score of 1. Here is an example of a patient with a score of 1. patient who is crying out or sobbing would get a score of 2. Here is an example of a patient getting a score of 2. No! Here are some key points to remember when assessing pain in critically ill patients. Consider that pain is present whenever there is a reason to suspect it. Whenever possible, obtain the patient's self-report of pain. A simple yes or no should be considered as a valid self-report. In the absence of self-report, look for changes in the patient's behaviors. The CPOT is a scale to help you detect these changes and score them. However, CPOT does not allow you to measure pain intensity. Remember that the CPOT helps you determine if pain is present or not. Always obtain a baseline CPOT score while the patient is at rest when you start your shift. Assess your patient again when he or she is exposed to procedures that are known or thought to be painful and look for changes. The patient should be attributed the highest score for the behaviors observed. Evaluate muscle tension last, especially when the patient is at rest. A CPOT score equal to or higher than 2 may be indicative of pain. Inversely, a decrease of 2 points or more on the CPOT score may be indicative of the effectiveness of your pain management interventions. The CPOT can be used in nonverbal critically ill adults with intact motor function and in the absence of brain injury. Indeed, brain-injured patients react differently to pain in comparison with other ICU patients. Research is in progress in revising the CPOT content to make it applicable to brain-injured ICU patients.
We hope you found this video demonstration on the use of CPOT useful. In closing, it is important to remember that patient self-reported pain should be obtained whenever possible, either by using a 0 to 10 self-rating scale or as yes or no questions. For additional information on the CPOT, please refer to the list of references on your handout. You can also contact Dr. Gelinas at her email, celine.gelinas@mcgill.ca. We would like to acknowledge Kaiser Permanente, Northern California Nursing Research, and Kaiser Oakland Medical Center Clinical Staff Development Department for their support in the production of this program. This video presentation was directed and produced by the Kaiser Permanente National Patient Care Services.